Hi, good evening, everyone. Welcome to the next lecture of the shoulder imaging series. Dr. Sahu, as you know, will be presenting on shoulder instability. First of the series was about normal shoulder. Today we'll be seeing radiological how to interpret imaging of the shoulder in cases of shoulder instability. Dr. Sahu, can we start now?
Yeah, good evening, everyone. We will be talking on the imaging of shoulder dislocation, shoulder instability. I will be showing a few introductory slides based on which we will be then discussing the cases which we have already done in few couple of months back. Whenever we talk of shoulder instability, the two most common things which come to our mind, both the clinician as well as radiologist, is we have to see whether there is any abnormality in the glenoid, and other thing is whether there is any abnormality in the humeral head. So these are the two components which form the glenohumeral joint. The instability basically happens in this joint, and the major components are the glenoid and the humeral head. So when we talk of glenoid abnormality, we are talking of either there is a Bankart lesion with where there is only the labral tear, or there is also bony defect in it. When we are talking of the humeral head, then something called as Hill-Sachs lesion is there, where there is a bony defect in the posterior superior aspect of the humeral head. So this is a diagrammatic representation which is showing the left-hand side image, which you see is the mid-range movement in the glenohumeral joint, and the right side image shows the extreme movement or the end-range movement of the glenohumeral joint. So here the triangular defect which you are able to see, my arrow is visible?
It's visible, sir.
Okay.
Yes, sir.
So this triangular defect which you are seeing is in the posterior superior aspect of the humeral head, which we call as the Hill-Sachs lesion. The defect is not exactly triangular, but just for the diagrammatic representation, it is being shown to be triangular. So in this mid-range movement, you're saying that even there is a Hill-Sachs lesion or defect in the humeral head, but the surface of the humeral head, which is in contact with the glenoid, is it is still there without any interference by the defect. Like in this range, there won't be any dislocation of the glenohumeral joint. But when the same defect, with the same defect and with the same shoulder, when there is an end range movement, you are able to see that this defect now comes and overlies the glenoid. So this is the time when the dislocation can happen. But then we have to see what sort of glenoid bony defect is there in the humeral head, and if there is any defect in the glenoid, which will further decide whether there will be a dislocation. If at all there will be dislocation, what type of dislocation will it be? So this is an example of the same defect of the Hill-Sachs which you are able to see, and this is extreme range of movement where you are able to see that the defect of the humeral head is within the glenoid cavity. So what happens in this case? There won't be any tracking off, like if the humeral head will not go out of the glenoid. Whereas in this case, if you see, the Hill-Sachs defect is larger than the surface of the glenoid. Now what happens? This is the mid-range movement. When there is a extreme range of movement, this will toggle off anteriorly because the gap in the humeral head is larger than the glenoid. So in that case, what happens? It will go out of the glenoid, and this is what is called as the engaging type of lesion. That means, so there is a defect of the humeral head which is larger than the glenoid, and once the movement goes to extreme range, there will be dislocation, and this defect gets engaged with the glenoid. So this is called as the engaging type or the off-track lesion. Whereas in this case, what you see here, the glenoid, there is no bony defect in the glenoid. Glenoid is normal shaped. The Hill-Sachs lesion is there, And in this is a different case where if you see there is also a defect in the glenoid, whereas the Hill-Sachs defect is similar to the previous, like on the image on the left side. So in this case, what happens, even the Hill-Sachs defect is similar to the previous one, but because there is a glenoid defect, this is again a engaging type of lesion. So what happens there, when there is a dislocation, this defect engages with the glenoid. So this is what is engaging type of lesion, and a non-engaging type of lesion is the previous case where we showed that the Hill-Sachs defect is within the range of the glenoid surface. Now coming to something called as glenoid tract, because the glenoid tract and the defect in the glenoid or the glenoid bone loss, that decides whether the type of lesion will be a engaging or non-engaging or on track or off track type. Now, if you see, this is an intact glenoid, and this GT is what is the glenoid tract. So what it is supposed, normally it is supposed that the humeral head engages with the normal glenoid to 83% of the diameter of the glenoid. So this,
Akram, welcome Akram. Can you mute your
Yes, sir,
mic?
I can hear you.
yeah. Good evening, sir.
Good evening. Continue. I'm sorry.
Yeah,
I joined late.
Yes, sir. So can you just mute yourself? Just there is background noise. Yeah. So I was talking of the glenohumeral joint engagement. So what happens, like 83% surface of the glenoid, that is the diameter, 83% of the diameter get engaged normally with the humeral head. So this is what is called as the glenoid tract. So what happens in case of the glenoid bone loss? So this is an example where the red area is the loss of the glenoid bone. So this diameter now becomes lesser. So the original diameter should have been this much, but because there is a loss in this anterior aspect of the glenoid, the remaining surface or the remaining diameter of the glenoid is this area, which is like capital D minus the small d. Now, in this case, the engagement between the humeral head and the glenoid happens with the 83% of the remaining diameter. Right. So in that case, if the glenoid tract, which we measure by the in the Excel, I will show how we measure it. If it is larger than the 83% diameter of the remaining glenoid, then it becomes a engaging or off track lesion. If the glenoid tract length is less than the 83% of the remaining glenoid, then it becomes a non-engaging type or a on-track lesion. So this is again an example where we can see this is a smaller Hill-Sachs lesion and this is a normal glenoid. So this will be a non-engaging type. Whereas in this case, there is a defect in the glenoid and the Hill-Sachs lesion is larger. So this will be an engaging type of lesion. Coming to like static images example. So this is what is called as the best fit circle method, where we measure the glenoid bone loss. So there are two different methods of measuring the glenoid bone loss. One is the best fit circle method. Other is the comparison with the other contralateral shoulder. Now there were previously studies and the concept that in order to get an accurate glenoid bone loss, we need to do a CT scan. But gradually, with the more advanced sequences, 3D imaging, and the thinner sequences, what we have seen that the glenoid bone loss can be calculated in equivalent confidence as the CT by doing thin section T1 sequence. So this is what is a T1 sagittal image. So in the best fit circle method, what we do is we draw an approximate circle, which we suppose that the inferior 1/3 of the glenoid is a circle, and this margin should, the circle margin should overlap the inferior and posterior aspect of the glenoid. And once we draw a circle, the remaining anterior part, if whether there is a glenoid loss bone loss or not, that can be seen if there is no bone here. So we have to measure that length or the diameter, and we have to compare it with the actual diameter of the glenoid. So this will give us the percentage glenoid bone loss. Other method is the contralateral comparison with the contralateral shoulder. But in that case, in MRI, we have to do again the MRI of a shoulder, the other side shoulder, which is not required. So, but in case of CT, what we do both the shoulder at one go. So it is easier to compare it with from the other side in CT, but not in the MRI. Other thing is, if supposedly there is a shoulder dislocation in both the shoulders, then the comparison, we cannot do a comparison. So that's why the best fit circle method has proven to be the most appropriate method. How do we calculate the glenoid tract? So this is the linear length of the glenoid bone loss, which we see. So this is the exact length. This green area is is considered to be with or without, maybe because there was a doubt whether this bone loss was present or not. Now this is another example where you can see the glenoid bone loss is larger, whereas the glenoid tract or the Hill-Sachs lesion is a smaller. So in this case, what it becomes a non-engaging type. Whereas in the previous one, there was a larger Hill-Sachs lesion than the glenoid bone loss. So it was a engaging type of lesion. Now I would try to show you some examples which are done in our hospital itself.
In the meantime, anyone has any questions? Amit, you can continue with the putting your cases.
Yeah. So, like, anyone has any question regarding what is engaging and non-engaging type lesion? Okay.
Niva? Hello.
So I think everyone is clear.
Yes, sir.
Yeah, Niva, you got everything correct, like engaging and non-engaging?
Yes, sir.
Okay. That's good.
So my screen is visible now?
Yeah, yeah.
Yes, sir.
Okay. So this is an example. So this is the axial image, which is a fat suppressed sequence, and I have told in my previous talk also, we now do a proton density fat suppressed image, which is called a PDFS.
Can
That
we
is
make this image bigger? Like,
is not visible.
it needs, yeah, now it is.
Okay, now it is full screen. Okay, so this is the axial proton density fat suppressed image. So this is the basic sequence and basic plane where we need to see both the Bankart's and the Hill-Sachs lesion. So I am moving from top. So this is the acromioclavicular joint, and as I move inferiorly, I am able to see this is the first section where I am able to see the humeral head. So in order to see the Hill-Sachs lesion, by definition, it should be the bony defect should be above the coracoid process. So this is the coracoid, and this is above it. So actually, the defect has started from here. But in our day-to-day experience, what we see that a lot of these things depends upon the positioning and the plane which we take. So by eyeballing, we can say very well that whenever it is a superior defect, so posterior superior defect, it becomes a Hill-Sachs. Why we talk of this as a bony landmark coracoid is because there is a normal anatomical shape of the posterior humeral head, which is little inferior, which is generally it is concave. So like this one. So there is a confusion if the bony defect is too large and it is reaching to this place. That's why by theory there is a definition that when the bony defect should be seen at the level of the coracoid or above it. So as I'm moving from superior to inferior, I am able to see there is a large eaten away bone which is seen posteriorly. That is the bony defect. And this is the Hill-Sachs lesion. If you can see, there is a large Hill-Sachs here which is extending from this to this level. And So we are sure from this image that there is a large Hill-Sachs lesion. Now, when we are seeing such a big Hill-Sachs, we would try to see what is happening to the labrum. So in PDFS sequence, the labrum looks darker. So this is the superior labrum, and as I move inferiorly, this is what is the anterior labrum, and this is the posterior labrum. In my last talk, I told that the posterior superior labrum is a bit of confusion many times because it is not seen as triangular and as dark as the anterior labrum. But in such cases, we need to see other sequences and other planes to confirm whether there is a tear or not, or whether there is an abnormal signal. Now here what we are seeing, the normal triangular shape of the labrum is not seen. Instead, there is a bright signal which is seen separating two parts of the labrum anteriorly. So this is what the tear is. Now if we see move inferiorly, we are able to see that this signal is all seen down inferiorly till the antero-inferior. Now we have reached the inferior part of the glenohumeral joint, and this is the inferior part of the antero-inferior part of the glenoid. So there is a large labral tear which is extending from superiorly till the antero-inferior part. So what has happened because of this large Hill-Sachs and the Bankards, there must be a tear in the antero-inferior labrum, and this tear has extended superiorly. Now in this case, what we need to see is whether this is again a engaging or non-engaging type of lesion, and whether there is any bone loss or not in the glenoid. So if we see this image, here there is some cortical irregularity which is seen. You can see there is a black cortex which is seen smoothly here. There is some signal here. So by this axial image, we are supposing that there may be some sort of bone loss, but definitely the labral tear is there. Now, in order to confirm that whether there is bone loss or not, we have to see a sagittal image. So this image is visible? Okay.
Yes, visible.
Yeah. So this is the sagittal image where you are able to see the whole rounded shape of the inferior glenoid is preserved, while there is some irregularity here in the anterior cortex. So definitely there is some degree of bone loss, but it is not very significant. And now in this case, if we draw a circle for the best fit circle method, just one second. So we have to draw an imaginary circle. We should try to fit the circle in the inferior and posterior margin of the glenoid, because we know that generally the Bankards is anteriorly. So in this case, if you can see, that whole circle is fit.
Amit, we are not seeing full screen.
Okay. Now?
Yeah.
You are able to see the circle now?
We can see circle.
Okay. So here, if we see, the whole circle is fitting on the glenoid. So there is no significant bone loss as such in this case, but there is definitely a large Hill-Sachs lesion. So this becomes a non-engaging type of bipolar lesion. Now, if we go to another example, so this is a different example. Again, I am moving from superior to inferior. The superior most part is seen as the glenohumeral acromio-clavicular joint, and then we are moving down to the this is the humeral head. Here, as we see, there is a small concavity which is seen in the posterior superior aspect of the humeral head. So there is a small Hill-Sachs lesion. Now, once the Hill-Sachs lesion is seen, but if you see, compare it with the previous study, there was also marrow edema which was seen. So that was like an acute type of dislocation, and there was a acute Hill-Sachs lesion. But here there is a defect, but there is no marrow edema. So this looks like there is a old dislocation which is there. Now we have to see whether there is a Bankart or any labral tear present or not. Now this is the superior most labrum. As we move inferiorly, this is the anterior labrum, this is the posterior labrum. Here the posterior labrum triangle is preserved. There is some abnormal signal which is seen in the anterior labrum. We are moving down to the anterior-inferior aspect, and here there is complete loss of the normal darker triangular signal of the glenoid. As we move more inferiorly, we are able to see that this dark cortex is not seen at all, and there is some blunting of the anterior-inferior glenoid. I am moving more inferiorly, and then the blunting is more evident. And there is absolute like U-shaped the blunting of the anterior-inferior glenoid. So here, by the axial image itself, we can see that there is definitely a bony, like bone loss in the glenoid. Now, in order to calculate that, we have to go to the sagittal image. But before that, I will try to measure the Hill-Sachs lesion. So this is what the Hill-Sachs is. So it is around 8 mm. Now let me calculate the glenoid bone loss. So we have already seen that bone loss was there in the axial image. Now this is the sagittal image. So as I move closer to the, this is what the absolute the glenoid should look like.
I'm not able to see full
Yeah,
screen.
so I'm just showing, I'm just putting the circle and then we'll put it.
No, we're not seeing the, yeah.
So here what you are seeing, there is a flattening of the anterior-inferior glenoid. If you can see this normal circle which was seen in the previous one. So here there is flattening. So now let's calculate what the So now I will try to calculate the glenoid bone loss by best fit circle method. Again, I'm trying to put the circle here. If you see, there is also a bit of flattening of the inferior glenoid. So along with the anterior-inferior, there is also inferior glenoid bone loss. So in this case, so this is the imaginary circle which we are trying to put. It should actually cover the inferior 1/3. So in this case, okay. So this is what it should be, the whole circle. Now we have to see how much is the measurement of this glenoid loss. For that, we have to draw length, and let's draw a line. So this is the actual diameter it should have been, but there is a bone loss of like 2.3 mm, and the actual diameter is 2.7 mm. So we have to calculate the glenoid bone loss by this thing, like 2.3 upon 2.7 into 100. That becomes the percentage. But we have to see that the 83% of this remaining diameter should be smaller than the Hill-Sachs lesion to call it as engaging type. But here, if you the Hill-Sachs lesion was like 8 mm, and if we calculate the 83% of the remaining glenoid, it will be definitely larger than the 8 mm thing. So it becomes a non-engaging type of or on-track lesion. Now let me show one more example where there will be like significant amount of bone loss. Okay. Sorry, this is the first one. Yeah. So this is a different case where you're seeing there is a good amount of glenohumeral joint effusion. And if you see there is a lot of edema in the humeral head, there is a big Hill-Sachs lesion, the depth is larger. And if you see the labrum, so there is tear of the anterior-inferior labrum. In fact, this is what we are seeing is a periosteal sleeve which has been slipped off from the glenoid. and there is flattening of the anterior inferior glenoid. So there is a Hill-Sachs, acute Hill-Sachs along with a Bankart's, and which is a bony Bankart along with periostal sleeve. So this is a type of Perthes lesion which we call. I have to show you the sagittal image to see the type of bone loss. So if we see, there is a small bony defect which is seen. So here there is a small Hill-Sachs and a small Bankart. We have to calculate the same way as we did in the previous cases to say.
Amit, we are still not seeing your full screen. Yeah.
Okay. So here, if you see, there is a small bony defect in the anterior inferior glenoid. So again, in order to call it as engaging, non-engaging type, you have to do the calculation as we did in the previous cases. Yeah. So this is another example. Where we are able to see a Hill-Sachs lesion. This is a large Hill-Sachs. If we are talking of Bankart's, if we see, there is like tear of the anterior inferior glenoid labrum. Now I think everyone can appreciate well that what is the tear of the labrum looks like. So there is a tear of the anterior inferior glenoid labrum, and this tear is again extending up to the superior aspect. So there is a whole anterior labrum is torn. But if we see this axial image, we are able to see that the triangular shape of the bony glenoid is quite preserved. So we think that there must be no significant glenoid bone loss. But the Hill-Sachs lesion is a large one. Now let's see the axial image, sagittal image, to find out whether the glenoid bone loss is actually there or not. So if we see here, there is a flattening of the anterior inferior. So there is definitely some amount of glenoid bone loss which is seen. This case also has a CT image. So I will try to show you the CT as well. Okay. Just I am reconstructing the axial into a sagittal one. So this is how we reconstruct it. Sorry, it is a little moving slow.
Till now, everyone is having any question, doubt, or because if there's a doubt, you can ask now. And in the next part, we'll be seeing the clinical part, that how we see engaging, non-engaging, Hill-Sachs on arthroscopy. That will be coming in the next lecture. But first, we must be sure how to do preoperatively. See.
So I have a doubt.
Yeah, Aniket.
Yes, sir. I have a doubt regarding the calculation of the glenoid track.
Okay.
Suppose there is a defect.
Yeah.
So whatever is the size of the defect, when we draw the best fit circle.
Yeah.
So first of all, we take the first full diameter. That is the large D.
Right.
Capital D. Then we measure the bone loss, small
Correct.
d.
Yeah.
Okay. So sir, when we take 83%.
Yeah.
So we have to take it for the large D, I think.
No,
Or,
so for the large D, no. So the large D 83% is when it is a normal thing. Now, when there is a bone loss, so what happens? Now there will be 83% of the remaining defect which is there. So that is what exactly will be engaging.
Yes, sir. I also thought so, but I have this doubt because we are subtracting that small d from that thing.
Yeah, correct.
So wouldn't be it be if we
Oh,
take
I got your
83% of the remaining thing, and
yeah.
again we are subtracting the small d from it. So I think we'll be overestimating the.
No,
Okay, Amit, you can then I'll see big D, capital D is the normal glenoid without a bone loss.
Yes,
But
sir.
engaging or non-engaging will depend on bone loss. The case will be with the same amount of hill sac, the bone loss will make it engaging or non-engaging. So we have to measure it from the small d minus small d, matlab d
yeah,
minus
remaining bone.
remaining bone.
Yeah.
Sir, I have a doubt too.
Yeah.
Yeah.
Yeah. Sir, could you mentioned this term bipolar lesion, sir? Could you, sir, elaborate, sir, once again, bipolar lesion, sir?
See, bipolar lesion is same thing. That lesion in the bone loss plus hill sac. That lesion
Okay,
is on the both side, anterior, posterior, glenoid, and humeral head. And
okay,
most of
sir.
the cases
Okay,
will have a bipolar lesion.
okay.
Okay.
Thank you, sir.
So this is the CT of the same case where if you can see, so there is flattening of the anterior inferior, in fact the whole anterior. So I'm not able to see in this. So in this packs, actually what happens, we should be orienting the glenoid in a plane which should be sagittal and oblique, where we can see the whole of the glenoid end face. Now this current packs which I'm using is not enabling allowing me to do that, but as such the glenoid bone loss is so much that there is a flattening of the anterior whole of the anterior glenoid. So I'm just showing you the example because CT of the same case was done previously and then we did a MR. Coming to another case. Okay, again the same way I'm moving from superior to inferior, and if we see here, so this is the last case. I would try to do the calculation over here and then we can decide whether this is an engaging or a non-engaging type. So the largest defect in the hill sac is in the whole lengthwise. I suppose it is here. So we have to take the length. So it is around 1.2 centimeters, right? And now we need to assess the labrum. So this is the anterior labrum. Definitely, as I'm moving inferiorly, there is complete non-visualization of the anterior inferior labrum, and you can see there is a flattening and obliquity of the anterior inferior glenoid bone as well. So there is a large glenoid bone loss, and there is a large labral tear. And this tear, if we see, I think it is all extending up to the superior part, the anterior superior part, but the superior labrum looks to be intact. So just remember the hill sacs which we have measured is a 1.2 centimeters. Now let's calculate the bone loss. So if we see there is complete flattening of the anterior glenoid, which is all extending till here, it should have been a round anterior inferiorly should be rounded. Now let's calculate the bone loss. So okay, so this is the best fit circle and so this is the diameter, and then this is the actual length of the bone loss which is there. So 4.6 of 2.7 is like
0.4.
0.4. So it is like 0.4. No,
Yeah,
we have to first,
centimeter.
yeah.
4.6. 27 minus 4, 22 point something.
Okay. 0.46 divided by. Okay, so it is coming out to be 17%. The glenoid bone loss is 17%. Now we need to calculate the on track or off track. So it is 2.7 minus 0.46 is 2.24, and it is 83%. So it is 1.8, and we got the hill sachs to be 1.2. So the hill sachs is smaller than the bank cards. So in this case, what happens? It will be a non-engaging type, right?
Sir, can I ask a question now?
Yeah, please.
Sir, so matlab first we took the whole diameter according to the best fit circle method, that was 2.7. And we subtracted small d, that is the glenoid bone loss.
Correct.
The remaining diameter उसका 83% हमने निकाल लिया. मतलब we are not taking 83% of the whole capital D जो हमारा बेस्ट फिट सर्कल से आ रहा था माइनस दी बोन लॉस. ऐसा नहीं है सर. मतलब पहले माइनस करके जो डायमीटर आया उसका 83% निकाल लिया. अब उसमें से सर दोबारा तो नहीं माइनस करेंगे ना?
नहीं. So we have already, this is the whole length, then we have subtracted this. So then this is what exactly is left, and then we have to take it. जो Aniket was asking now, and he
Yes,
messaged.
sir, that's what I was saying कि उसमें हम
Yeah.
overestimate कर रहे हैं.
हाँ, कंफ्यूज हो रहे हैं हम लोग ना कि मतलब हमें कितनी बार माइनस करना है.
नहीं माइनस
इसमें सर 2 बार माइनस हो रहा है एक्चुअली, क्योंकि
नहीं.
ग्लिनॉइड ट्रैक जो हम लेते हैं वो शायद पूरा एक हम रेफरेंस ले लेते हैं कि ये बेस्ट फिट सर्कल पे वो ग्लिनॉइड ट्रैक है हमारा.
हाँ, सो अगर इसमें इफ यू सी ये वाला जो द सजाइटल इमेज जस्ट हुई,
Amit, we cannot see. Yeah.
सो इसमें द ग्लिनो, एक सेकंड. Yeah, so this is the hill sachs. So this
Yes.
is the length of the tract which we measure, right?
Yes, sir.
So this is 1.2 centimeter now. Now here what we have measured is the glenoid bone loss. So first we have to, by best fit circle method, we have measured the glenoid bone loss to be 17%. Right? Now, in order to calculate it, whether it is on track or off track, so we have to see for engaging type, or which is off track. In that case, what happens? The hill sachs or the glenoid tract should be larger than the 83% of the glenoid bone loss, like the whatever the remaining part is. Now, Aniket, you are asking the question is like whether it should be 83% of the whole or 83% of the this remaining, right?
Yes, sir.
So it is supposed that this is what the remaining bone is. So iska 83% of this, the remaining bone, that will be calculated, and that will be supposed whether that is engaging or non-engaging type.
तो सर हम जब 83% रिमेनिंग का लेंगे और उसमें से फिर से हम जो ग्लिनॉइड बोन लॉस है वो माइनस करेंगे, स्मॉल डी हमें फिर से माइनस करना है ना?
नहीं, फिर से नहीं करना.
माइनस तो पहले कर लिया है. माइनस पहले कर लिया.
एक बार तो माइनस कर लिया ना. So this is suppose 4.5 minus 2.5 minus 0.45. So whatever remaining, ये तो एक ही बार माइनस किया. Then we are taking 83% of that. अनिकेत को मैसेज किया कि वो it is from the larger D. अनिकेत.
हाँ सर.
नहीं तो नहीं.
Should I intervene?
Yeah, please.
देखो, हमें बोन लॉस को कैसे करेंगे. पहला वाला जो है, जो बेस्ट सर्कल से डायमीटर आ रहा है, उसके अंदर बोन लॉस नहीं है.
करेक्ट.
तो इसलिए हमें पहले माइनस करके, माइनस जब कर दिया उसका 83% लेंगे.
हाँ, so that's what I was talking of.
वही मैं I'm saying the same thing.
सर मतलब
पूछ।
पहले ये मैं भी यही सोचता था, बट एक बार वो जो आर्टिकल मैंने पढ़ा था एक दो, एक की
हाँ
आपको फोटो भेजी है, तो
हाँ
उसमें वो जो कहते हैं कि आप 83% पूरे डायमीटर का लो और उसमें से स्मॉल डी माइनस करो।
ओके, सो मतलब मे बी दैट आर्टिकल इज देयर, वो शेयर कर लेना ग्रुप में, विल रीड। बट जनरल प्रैक्टिस व्हेन वी कैलकुलेट, सो दिस इज हाउ वी कैलकुलेट इट। मतलब देयर आर आर्टिकल्स व्हिच से ना कि स्मॉलर आफ्टर द बोन लॉस यू हैव टू कैलकुलेट द 83%। जो वो आर्टिकल है वो एक बार शेयर कर, विल डिस्कस, दैट इज गुड।
दोनों में एक ही बार माइनस हो रहा है ना,
हाँ
दोनों केसेस में एक
मतलब
ही
बहुत
बार
ज्यादा
माइनस
फर्क
हो
आना नहीं चाहिए दोनों में, क्योंकि कोई ज्यादा फर्क आना नहीं चाहिए दोनों में वैसे।
हाँ, मतलब अगर उसमें ऑन ट्रैक और ऑफ ट्रैक डिसीजन पे दैट वोंट मैटर आई थिंक, बट स्टिल वी हैव टू, मतलब इफ देयर आर सम रिसेंट आर्टिकल्स देन लेट्स शेयर, विल सी।
हाँ, इसमें देख लेते हैं, कंफ्यूजन रहता ही है इस चीज में कि
पर माइनस एक ही बार होगा।
हाँ हाँ, माय सब्सट्रैक्शन शुड बी डन ओनली वंस।
ओके सर।
ठीक है। So this was what like how we calculate, like when we have to see how the bank card is there. When we see a bank card, whether there is a labral tear or there is along with that there is bone loss, then we have to see the heel sachs lesion to see the glenoid tract, and then we have to do the calculation to finally come to a conclusion whether there is a engaging or non-engaging type of lesion. So this is what in gist is like. So along with that, we have to also see any other pathology. If we can see, most of the time there is the rotator cuff is intact, but in some cases there can be tear of the rotator cuff as well. Similarly, there can be also not only tear of the anterior labrum, there can be tear of the superior and posterior labrum as well. So not only when we are seeing that there is a bipolar lesion, we are once we have seen, there should not be the satisfaction of search that we have seen a heel sachs, we have seen a Bankart, but we have to also see overall what other pathologies are there also, right? And then I showed some 6 examples. So this is what it is. Any questions? Any more questions?
Amit, what about reverse heel sac and posterior?
Okay. So reverse heel sachs and reverse Bankarts.
Yeah.
So if reverse heel sac Bankart will be, there will be a posterior inferior defect in the glenoid. So that is reverse of the normal Bankart, where we will be seeing a defect in the posterior part of the glenoid, like there will be flattening, similar as we are seeing here. In case of reverse heel sachs, so there will be a antero-superior defect in the humeral head. So instead of the heel sachs which is seen posteriorly, at the same level we'll be seeing the defect in the antero-superior humeral head. So in that case, sometimes we have, I couldn't get that case, didn't have the ID. We had an example where there was both heel sachs and Bankarts. Along with that, there was reverse heel sachs and reverse Bankarts. I think, sir, you have operated that case, right?
Yeah, we have operated that case. We have discussed as one of the radio conferences also.
Okay.
Yeah, we have
So I
discussed
can show that if I can get the ID, I will show this in the next time whenever we will do the next topic.
About slap, Akram. Akram, are you there?
Yes, I am there.
Yeah, any questions?
Only thing is, for a surgeon, it is more important.
So your voice
Am
is,
I audible?
your
Yeah,
voice,
yeah.
now you're audible.
So I think the percentage of bone loss by best circle method is more important than delineating and confirming that whether it is an off track. Yes, it will give a surgeon an idea, but definitely it is an intraoperative more important finding to see whether it is engaging or non-engaging. I think percentage of bone loss would make us decide whether to go for a soft tissue procedure or a bony procedure.
Okay. So another thing,
I'll put it in other words, Amit. See, when we are planning a surgery, see, usually imaging is done to plan a surgery. Once we are inside, we have made a plan. Usually we execute the same plan. So the percentage of bone loss is the thing which we are always more interested. Earlier, we used to get the CT scan done in addition to the MRI, but with your circle method, we're getting MRI only, because if bone loss is 20% or more, or we have different people have different criteria, we would like to replace bone with the bone rather than doing a soft tissue procedure, because chances of failure in of soft tissue procedures in a higher bone loss are high.
Okay.
That's what Akram wanted to say. So this is very important to get for us to get a, because on track, off track, many times we can make assessment on table also by rotating and with the scope inside and rotating, and we see the Hilsac is engaging with the anterior part of the glenoid or not. So that is one important thing. Other important things, like we should know, like you already mentioned, that we should have a know about other related things, like is there a rotator cuff or posterior. Many times we are seeing a posterior labral tears along with it. So those things are becoming more and more important, because then we can plan accordingly. Like if we are doing a posterior labral tear, usually then we won't be doing a remplissage.
Right.
So that is where planning is there. Other thing, if you have any this thing for the slab, do you have any image for the slab?
No, right now I don't have.
Okay.
So this slap and the
This-
reverse Bankart itself, that I will show these two examples, I will show next time.
This Broadford lesion, like many times we see the report that the superior labrum is not seen, could be connected. Could you just theoretically put some light on it?
So, like imaging wise, when we call it as a slap or the superior labral involvement, so in this case, I'll just show you. So here you're able to see a uniform dark band. So this is the superior labrum, and you can differentiate between this and this appearance. So here you are not able to see the labrum at all, and there is some irregularity. There is some thin dark band which is seen. Whereas if we come to the superior labrum, we are able to see the superior labrum as intact. So in case of slap, there will be a tear that will be moving from anterior to posterior in the superior labrum. That is how it should be seen imaging wise.
What about Broadford lesion when there's a hyperplastic?
Yeah. So in that Buford complex, what happens? There will be a defect in the, so generally it is defect in the anterior-superior part. And along with that, what we see is there will be a thickening of the MGHL, which will be seen as another like a dot-like structure and thickened band-like structure anterior to the labrum. So, and in Buford complex, what happens? There is a specific location where there will be a defect. So, the anterior-superior labrum, it will be defect, and the rest of the labrum will be looking absolutely normal. And there won't be irregularity of the labrum as we see in the tear. So, that defines a Buford complex versus a tear.
And just
Also,
for the completion's sake, ellipsa lesion, just talk over one.
Yeah, so again, it is ellipsa. There is the tear of the superior labrum from anterior to posterior. Other thing which I was talking of was the Buford. Along with Buford, we do see sometimes a focal defect in the anterior superior labrum, which either can be a recess or a foramen. So many a times we get reports that this is a focal tear, but actually that is not a tear. That is a normal anatomical defect which is seen in the labrum. And then we also get the Hagel and Bagel type of lesions where there is humeral avulsion of the inferior glenohumeral ligament. In that case, this is what the inferior glenohumeral ligament is. And in case of Hagel, there will be humeral avulsion. And if there can be also glenoid avulsion of the inferior glenohumeral ligament. So these are the different names which are given to the different types of labral tears. But many times we don't name them specifically. It is better to describe them so that the orthopedician also understands what we are talking of. And we can also when we not give a name, when we explain it, so we can better explain it from the extent and the structure which are involved, or the extent from where the tear is there. So this is what we prefer to, rather than giving names.
Yeah, Pallav, Neva, Neha, you wanted to ask something?
I'm done, sir. No questions right now.
So one thing from my side, you told that when there is a large bony defect, you go for a bone graft or a different type of, rather than soft tissue. So there is like we have also done a thesis like 4-5 years back, and there is also some papers which say that in Bernaghi view we can see the glenoid bone loss very nicely if it is more than 15%. So like if we clinically you are very sure that there is no other like abnormality other than the glenoid bone loss and the Hill Sachs, would you prefer going directly to the OT with just a Bernaghi view
No.
if there is more than 15% bone loss which is seen in the X-ray?
Usually more than 15 or 20%, depending on profession of the patient.
Yeah.
We would like to get a MRI done. Reason one, when you're doing a open procedure, you just do, see earlier what you used to do, procedure would remain same. Like people
Okay.
would, when open procedure, they would do same procedure, both the thing, and they'll open and see, and they'll put a bone graft or either do a putty plat or things like that. But
Okay.
nowadays we would like to have MRIs so that whatever we do, we have to be very sure about uh, anatomy, and we can combine the two procedures. If there's a bone loss and a big Hill Sach, I can do arthroscopically, we can do a remplissage, and we can put a bone block anteriorly. Those
Okay.
things can be done. So I think it is always better to have a MRI and good MRI. And as I would say, the role is that we should not be relying on radiologists only. I'm not talking about you, but a lot of scans we are seeing from outside.
Right.
And Amit, you know, whenever I'm in doubt, I always refer these things
Yeah.
to you just to. So we should have some kind of knowledge about imaging, because we cannot blindly follow the report, because we don't know, if we don't know the person who is reporting,
Right.
then we can land up in trouble.
Yeah, and most of the time I see that when there is clinical doubt, then only you send the imaging if there is a discrepancy, and most of the time it comes out to be like definitely there is some abnormality with it.
Discrepancy, always we take a second opinion
Yeah.
of the
So the last one thing. So when sir you're repairing the bankart, so there was a like I was reading an article and there was one of the talks also saying that when you decide on the table, suppose there is a bankart, you have repaired the bankart. After repairing the bankart, then only you decide whether what to do with the Hill Sachs, like you dynamically.
most of the time, see, once you go, you do a diagnostic scopy,
Okay.
and then you see a engaging or non-engaging. If you're seeing a engaging, then you should, you put in your anchor and sutures beforehand. You don't tie. See, remplissage is done tied in the last, because once you tie the remplissage, nothing much is left to be done. So we just pass our sutures,
Okay.
and we don't tie them posteriorly in the remplissage or in the, for the Hill Sach lesion. We repair the bankart, then we
Hmm.
come back. That is the last procedure. We tie our capsule to the Hill Sach lesion.
Okay. So after repairing the bankart, then you do the dynamic maneuver and then do the
No. Before. See, after
Okay.
doing repair, the maneuvers are minimal, and they change drastically. I think it's a good idea. Next time we'll be showing all the arthroscopic things, what we do, pictures, maneuver before, then do the repair. Because after doing the repair, your maneuvers, they don't work. If it is, you have done a repair, and if it is still engaging, that means your repair is not doing anything good.
Okay. Okay. So because there was a discussion on this in one of the panel discussions in this ISS when I went to London. So there were some surgeons who were talking that we do the repair the bankart, then do the maneuver, and then decide what to do with the Hill Sachs.
Akram, you want to say something? No, we actually maybe they are doing we usually play safe, and we would
Yeah,
like
that's
to
true.
do.
Like once you have repaired it, then again, if you do maneuver, there are chances that there is a like the tear.
See, we're not doing a lot of stresses after the repair.
Yeah, correct, sir. Okay.
Ballav, any question?
No. Sir, can I ask a question?
Yeah.
Sir, which modality of investigation is good for this bipolar lesion, sir? CT, 3D reconstruction, or MRI?
So we discussed now. So like previously, for the bone loss thing, people were more relying on CT because the MRI advanced machines and the sequences were not there. Now, as I showed you the example, I just showed you the CT just to show that how the bone loss looks like in CT, and incidentally the CT was done before the MRI. I think from a different institute. That's why. But otherwise, all the examples which I showed, we were very confident that there was whether there is bony Bankart or not. If there is a bony Bankart, what is the glenoid bone loss which we are seeing? So there is no requirement for radiation and doing another modality. In the MR, we
Okay,
can
sir.
see both soft tissue as well as the bony defects.
Okay, sir.
The only thing is it should be done in a proper sequencing. That's important.
So, Pallav, whenever you're asking for a radiologist for MRI, you just tell them, or like I always write MRI shoulder for instability.
Right.
Then they know what all things I'm asking for. I'm looking for bone loss. I'm looking for Hill-Sachs lesion. So just one extra word and everything is conveyed.
Right, sir.
What do you suggest, Amit?
Yeah, yeah,
Should we write
absolutely.
anything else?
No, absolutely. So we do that. So in fact, there is a sequence which is T1 sagittal 3D, but the all the PDFS images that's also we are doing in thin section. So it gives the same accuracy as the thinner or the 3D sequences. It takes more time, and like why to like the patient why to lie down for so long. So by this basic sequences which we do properly, we can able to predict the bone loss and the soft tissue abnormalities.
So,
Fine.
Hiba, you want to ask anything?
No, thank you.
Sir, hello. Is there any X-ray views possible to identify bipolar lesions, or MRI or CT scan is
Yeah,
must?
that's what striker notch we used to get a striker notch view by abduct 90 degree abduction,
for
90 degree
Hill-Sachs.
forward flexion to get the Hill-Sachs. But with all these modalities, see, X-rays, you won't be operating by looking at X-rays only.
Right, sir.
I don't know, matlab, like nowadays,
Yeah.
so much of this thing, information and everything. Akram, what do you say? I think Akram has left.
No, he's there. He's muted, I think.
So, see, now with so many modalities available now, MRI is available wherever shoulder scopy is being done or shoulder surgeries are done. I think MRIs are available.
Yeah, agree.
Okay, sir.
And X-rays are not so reliable and reproducible. See, if your angle is different, notch view, the rotation is little bit different, everything changes. And
Okay,
even
sir.
our radiographers are not so skilled to give all those special views. What do you say, Amit?
Yeah, sir, I agree. Absolutely agree. They have the literature says a lot of things that X-ray, but still, like MRIs should be done before going to the OT.
Okay, sir.
So should we conclude? It was a
Yeah, I think so.
very nice talk. Any questions from radiology people?
Neha, Aniket, anything?
No, sir.
So we'll
No,
have another talk on this instability, a small talk. Next talk is on rotator cuff. Before that, I'll put in a 10 minutes just to make aware arthroscopy, what we see and how do we look at things from
Yes,
a
sir.
different perspective.
That will be interesting. So we just for the orientation, like how what we can do, like we can correlate 1 or 2 cases MRI and then the arthroscopy.
Yeah, whatever you should, we put in a one case, and it is just like seeing what you are showing in images. It is like seeing that live thing. So I
Right.
think next time I'll take 10 minutes from your talk,
Yeah,
that
we'll do that.
rotator cuff, and
Yeah.
we'll present on Bankart as well as remplissage and few other things.
Yeah, and I will show those 2 examples, like the
Yeah.
slap and
Anterior plus
reverse.
anterior, reverse Bankart and reverse sach.
Exactly.
Okay.
Okay, thank you.
Good night, friend. Good night.